Hello. Good
Yes,
evening,
sir.
good evening, everybody. Welcome to this month's Journal Club. This is a original article. Um, it is a kind of pilot study, single arm, I think, prospective study um, regarding management of fistula in and Praveen is going to talk about it. Over to you, Praveen.
Yes, sir. Good evening to everyone. This is a prospective single-arm study to evaluate the safety and efficacy of an autologous blood clot product in the treatment of anal fistula, conducted by Edward Ram at Department of General Surgery in Israel, and it was published online in 2024 in Disease of Colon and Rectum Journal. And the impact factor of the journal is 4.4 and SCR is 1.005. Coming to introduction of the paper. Anal fistula is a common and frequently disabling medical disorder which affects millions of people worldwide, and it occurs when there is apparent drainage tracts which connect the anal canal and rectum with the skin around the anus. It is classified based on its anatomic location and relation to external sphincter muscles. The main factors affecting the ability to successfully manage the fistulas are fistulas with multiple tracts, persistence of inflammation, it may be due to untreated sepsis or granulation tissue, and inability to accurately locate and close internal openings, and due to active Crohn's disease. Surgical treatment remains a standard of care for perianal fistula disease, and fistulotomy is highly successful for simple transsphincteric fistulas. However, this procedure risks some damage to external anal sphincter and its subsequent incontinence. Recently, efforts have shifted to various biological products, including fibrin glue, mesenchymal, and adipose-derived stem cells, with hope of avoiding anal sphincter injury while permanently occluding the fistula tract. But the robust clinical trials have produced only moderate success rates despite significant treatment costs. And the result is this biological interventions are often restricted to very specific patient populations. RD2 version 2 is an autologous whole blood clot treatment created from patient's peripheral blood at the time of procedure. And this treatment was found to be safe and effective in acute and chronic soft tissue wounds. This blood product is applied to the entire wound surface, thus creating a temporary scaffold and matrix to facilitate tissue healing. The aim and object of this paper was to explore the safety and efficacy of RD2 version 2 treatment for closure of simple and complex transsphincteric canal fistula. This report is an interim analysis of prospective pilot study which aimed to examine the safety and efficacy of RD2 version 2 in patients suffering from transsphincteric canal fistula, and it was conducted in a large tertiary medical center in Israel, which was initiated in April 2021, and it is currently ongoing. They included the patients of aged 18 years or older with transsphincteric cryptoglandular or Crohn's disease-related anal fistula confirmed by MRI, and patients with prior failed attempts at fistula closure were also allowed. And patients with active luminal IBD involving any portion of J tract, patients with any malignancy, and patients with life expectancy of less than 24 months, and with prior medical history of coagulation disorders or abnormal platelet functions, and on systemic steroids use. And patients with IBD were excluded if they were suffering from any abdominal or external intestinal symptoms or if they are actively treated. The study population consists of aged 18 years or older with transsphincteric anal perianal fistula confirmed by preoperative MRI, and of these 60 patients were screened for this study. 7 patients were excluded from the study after MRI determined the presence of intrasphincteric fistula amenable to fistulotomy. Hence, 53 patients who met the inclusion criteria were enrolled in the study and were given the RD2 version 2 treatment. This procedure was performed in an outpatient setting, and patients without a prior colonoscopy within 2 years from a surgical intervention were recommended to undergo a screening colonoscopy before the surgery. And the procedure was performed under general anesthesia and following were the surgical steps, which includes first debridement and cleansing of fistula using a fistula brush and hydrogen peroxide, followed by saline rinsing to remove any remains of hydrogen peroxide. Later, suture closure of internal fistula opening was done, which was confirmed by water leak test. And installation of RD2 version 2 preparation was done. Here, we are locating the fistula, probing of fistula is done. Then debriding the fistula. Then cleansing with hydrogen peroxide and washing with saline to remove the remnants of hydrogen peroxide. Then suturing the internal opening. And water leak test was done to check the internal orifice is blocked or not. Then autologous blood clot was prepared. It was instilled from internal opening to external opening and was packed with gauze.
From external to internal, not internal.
So from internal to they pulled out the external. So
Yeah, but yeah, you have to put the catheter in and instill it and as you go along.
yes, sir. This RD2 preparation was done by this method. 18 ml of blood was drawn from patient, and this blood was collected in acid citrate dextrose at 9 vacuum tubes, and it was transferred to activation valve, which was containing calcium gluconate and guanine powders. This preparation was installed during withdrawal from fistula tract from closed internal opening to external fistula opening, and the operative field was observed for approximately 5 minutes to assure coagulation. Post-operatively, the patients were given oral antibiotics of ciprofloxacin and metronidazole and were prescribed stool softeners, both based on surgeon's discretion. And patients was followed up at the clinic after 1 week, 2 week, 1 month, 2 months, 3 months, and 6 months after the procedure. Long-term follow-up is to be conducted 12 months after the procedure. Clinical efficacy was assessed using fistula clinical symptoms compared with baseline. And these symptoms include discharge from fistula, healing or remission of fistula tract, and external opening. And symptoms were graded on a scale of deterioration, no improvement, minor improvement, medium improvement, and significant improvement. Complete healing or remission was defined as absence of any anal symptoms, including pain and discharge from fistula, and a clinically confirmed closed external opening, which were validated with a postoperative MRI. And this postoperative MRI was performed at 6 months in all patients, and healing at 12 months was evaluated clinically. The study outcome was the healing rate by 6 months of anal fistula treated with RD2 version 2, which was defined as absence of any anal symptom with no discharge from fistula and a closed external opening.
Okay.
Reading.
Yeah, wait. Let us start with Ainaz. Ainaz,
Yes, sir.
so what is your critique of the paper so far?
Sir, so the study is a relatively recent study, sir. It's still ongoing. And in addition, it is published in a journal which has an impact factor, sir, which is considered to be good.
There
Yes,
is some
sir.
problem with your audio. Hello?
Is it audible? Hello. Sir, am I audible now?
You are either too loud or you are very faint.
And now am I audible, sir? Is it better? Yes,
Yeah.
sir. Sir, it is published in it is a relatively recent study, sir, and it is published in a journal which has an impact factor of 4, which is considered to be good, sir. And in addition, it's a prospective study, sir. So these can be considered as a pro point for the article, sir. But throughout the study, it's an open label study, but there's no control group, sir. And so because of that, that can be considered as a con for the study.
No. See, you can't consider that because they have not claimed it to be a randomized controlled trial.
Yes, sir.
They have just
Uh,
done prospective observational study as a pilot study. They have not compared the two groups. So
Yeah,
you
so,
can't say, having no control group, yes, it can be considered as a negative, but not as far as the study is concerned. In the final outcome, you may say that, but not. See, if for example, you find a new, either an operation or a drug or whatever, and you want to see whether that particular operation or that particular drug or that particular procedure is effective, you will do it in a small group of patients, and that's called a pilot study. If the results are good, then you would say, let us now do it do it as a randomized control trial. You usually don't start off with the RCT straight away unless it is something which is very groundbreaking or something very effective. Then you can do an RCT straight away. But generally, pilot studies are a very accepted modalities of study. Okay, Nikita,
yes, sir.
what is your critique?
Sir, almost the same, sir. And along with that, interim analysis, sir. So they have mentioned it to be an interim analysis. At the same time, they were commenting it to be a pilot study. They are both different, right, sir? So
No. See, the thing is, why have they said it's an interim analysis?
they initiated it as a clinical trial, and at some point they just started doing analysis to know the efficacy, sir, like to know where the study is going. But the pilot study in general is like we take up a protocol is separate for a pilot study, no, sir. It's altogether different
No.
study.
I think, see, you are confusing. See, basically, when you talk about fistula, the efficacy of the treatment or surgery, you have to look at it as long term, because short term, many of them will have very good results. It's the long term results which actually make a particular treatment good or not so good. So here they have only followed for a period of 6 months or 1 year. So they have said probably, I think, I don't know whether we can get access to their original protocol. Probably they have set it out to do a study maybe for 3 years or 5 years, I don't know. But they have come up with the interim analysis to see whether it's actually effective or not. Sometimes it is good to have an interim analysis, because if the treatment is no good, no point continuing the study. So that is why I think you are confusing the pilot study to interim analysis. I don't think there is any sort of connection at all.
But they mentioned like multiple times about it being a pilot study, sir.
So pilot study means basically they are only looking at a small group of people. They are just doing a prospective observational study, and then probably they may want to do it as a randomized control trial. I don't know. They have not.
Nikita, when we also do the study, when we like short-term results, when we want to present it early or something, and we also want to know the results, we say that we will do it presented as a pilot study, and then we will continue to do. So probably they also want to look at the results at 6 months, and then they will continue it as a prospective study or whatever. So that is what they're probably meaning like interim analysis, because
So,
you want to know the short-term results now after 6 months, and then if there are enough good results, like if they're matching with the literature or whatever the recurrence rates, probably they would want to continue it as long term.
Yes,
So
sir.
that's why they are calling it as an interim analysis, probably.
Yes, sir. But can we use the terms interchangeably, sir? No, they
Maybe they are like probably, I don't know whether you're right to use the change interchangeably, but that is what they mean, probably. That is what we are assuming.
yes, sir. And the other points, they used proper definitions for the inclusion criteria and also for recurrence with proper references. And
Okay, good.
follow-up is adequate, sir, as per the protocol.
You know,
Sir, regarding the patient inclusion, sir.
hello.
Hello.
Ah,
Sir, audible, sir?
you are not, I don't know, your voice is not very clear.
Just of the speaker. Sir, regarding inclusion of the patients, I think they would have more narrowed the patients, sir, because they have included all the patients whoever from simple to complex.
No, they have not included simple. I think that is what they very clearly said. The intersphinctic fistula, they on MR scan they found 6 of them or 6 or 7 of them, and they've excluded them. They have only included complex fistulas, but they have also included people who have been operated before and everything, which is good of them because that is positive rather than negative.
Okay. Because sir, if it is a recurrent, sir, the surgery was already done and there is high chance of recurrence for the same patient if you include all these patients.
Correct. So if you include more difficult patients and show that this treatment works, then what is wrong with it?
Because the recurrences are anyway always high always, sir, because of this.
Sorry, but see, that is what they have taken the risk. They have said we will include even the complicated ones, we'll include the recurrent ones. If it works, then it's good. But they have honestly depicted their results.
Yes, sir.
So I don't think it's wrong.
Yes. Okay.
Okay, what else? Tanya?
So nothing to add, sir. Just one advantage would be using patient's own blood to do this study, which would be less expensive and easy to create that autologous clot.
Okay. Nitya?
Sir, they have said patients on antiplatelet and oral anticoagulants were eligible. But in the exclusion criteria, again, they have said patients with abnormal platelet function, prolonged PDT are excluded. That part, they should have been a bit more specific, I feel, sir.
Praveen, is that true? Because I didn't catch that.
The actual journal, page 543, there is a sentence, sir, that in the materials and methods, the study participant may, the next paragraph, like in the study participants, the next paragraph, there is a sentence saying that basically the inclusion criteria, I'll just read it out, sir. 53 patients who met the inclusion criteria were enrolled in the study and received the study procedure and RD2 versions treatment. Inclusion criteria included patients aged 18 years or older with transsphincteric cryptoglandular or Crohn's disease related anal fistula confirmed by MRI. Patients on antiplatelet or oral anticoagulants were eligible. Patients with prior failed attempts at fistula were also allowed. And exclusion criteria included patients with active luminal IBD involving any portion of the GIT, any malignancy, life expectancy of less than 24 months, prior medical history of coagulation disorder and or abnormal platelet function, prolonged PT, APDT, and systemic steroids. So those two are, they could have been.
No, they only include there, they have said oral anticoagulants and antiplatelet agents. But
prophylactic.
No, if for example somebody is, he has ischemic heart disease or a pulmonary embolism and they've had, so such people have been included, but patients with congenital disorders have been excluded. So nothing wrong with it.
Okay.
Nitya, similar to our cases, our surgery cases that we do know. If patient is on antiplatelet and anticoagulant, doesn't mean they have deranged platelet function and all. PTI, APTT, everything will be normal, so we take up for surgery. That is
Okay.
just the basic criteria for surgery. I think they are just mentioning there.
Okay. Okay.
Okay, Praveen. Niranjan, anything to add?
Nothing, sir. Nothing, sir.
Okay.
Just that patient being on antiplatelets, usually PTNR will be normal. So they only like produce the platelet aggregation will be delayed, but not that the the dysfunction will be there.
Yeah.
Okay.
So I don't think it is wrong to
Okay.
include them.
Praveen, not results,
Yes.
man. What are the critics?
Sir, the same, sir.
Nothing. What is the difference between SDR score and impact factor? Which is better?
Sir,
Hmm.
both are same, sir, but SCR, it shows the quality and reputation of journal, sir, additionally.
That is a recent addition. Previously, we only
Both
had.
are not same, no, Praveen. One is the
Sir, no, sir.
uh,
SCR, it gives the quality and reputation of journal, sir.
correct. Impact factor is the number of times it has been
Number of
quoted
times.
in that particular this
Yes,
thing.
sir. Yes, sir. Number of citations from published article
Correct.
in last 2 years, sir.
Okay. Fine.
Yes.
See, randomization is not against. See, in this, every study cannot be a randomized control trial. Initially, you have to do, sometimes you have to do a pilot study, see if the efficacy. For example, even drugs, for that matter, you start the treatment, and if there are major side effects or if it is not effective, for example, many trials have been stopped because the drug was found to be, very, having a lot of complications or something like that. So, you can't start all studies by doing a randomized control trial. Especially in surgery, RCTs are very difficult to do. So I think that is randomization, they themselves have, put it later, as a, one of the negatives of the study, but I think it is okay. So I don't think we can take it strictly against, against the study. Okay, carry on.
Okay, sir. Coming to results, as total of 53 patients who are met inclusion criteria underwent the procedure. Among those, 4 patients did not complete follow-up. Of them, 3 withdrew informed consent before the follow-up portion of study, and 1 was lost to follow-up. Majority of the patients were men with a median age of 42 and had cryptoglandral anal fistula. MRI findings diagnosed 19 patients as having simple and 34 patients as having complex anal fistula, and 25 patients had a sit-on present for at least 6 to 8 weeks before the procedure, but the sit-on was removed at the time of procedure. 40% of patients had failed other interventions ranging from 2 to 6 prior treatments before this procedure, which includes fistulectomy of 7 patients or ligation of intersphincteric fistula tract of 4 patients. And this is the demographic table. Coming to the interim results analysis, at the time of this analysis, 49 patients had reached the 6-month follow-up and 33 had reached 1-year follow-up. At the 6-month follow-up, 34 patients were healed after this treatment, and at 1 year, 20 subjects reached the complete healing. All the patients who achieved the healing at 6 months remained healed at the 1 year. A total of 20 patients were presented with multiple tracts, and 13 patients had multiple openings and multiple tracts at the time of procedure. And out of them, 13 healed by 6 months, and 13 patients with multiple tracts, 9 had healed by 6-month time frame. And they have done a Kaplan-Meier analysis which showed that median duration of success was 379 days. And this is the study flow chart. Initially, there was total of 60 screened patients, out of whom 7 had failed screening. So 53 patients had undergone the treatment, OD2 version 2 treatment. Out of them, 3 had withdrew consent and 1 was lost to follow. So at the end of 6 months, 49 patients were there, and out of whom 34 was healed and 15 there was failed patients. And out of 49, at the end of 12-month follow-up, 33 patients had reached that 1 year, out of whom 20 had healed and 13 had failed. And 16 patients follow-up is still going on. And they have done a sub-analysis with Crohn's disease patients. 9 patients with perianal Crohn's disease were enrolled in the study. At the time of enrollment, 8 patients were on maintenance treatment with biological therapy for their Crohn's disease. At this time of analysis, all the 9 patients reached the 6-month follow-up, and only 7 of them had reached the 12-month follow-up. At 6-month follow-up, 6 of the 9 patients were healed, and 1 patient showed progression toward healing, and 2 patients were considered initial treatment failures. At the 1-year mark, 5 of the 6 patients ultimately remained healed, and 1 patient failed at 1 year. And this was the picture of procedure day and after 3-week follow.
Okay. Nikita, will start with you. Critique the results.
Yes, sir. I got pretty confused at the point of analysis, sir, because they mentioned at the point of at the time of analysis, 49 had reached 6-month analysis and 33 had reached 1 year. So these 33 are included in that 49, or are they separate, sir? Because
Of
if
course.
they are
No, there is only 49 patients in the study, 53 patients in the study. Out of them, 3 withdrew consent, 1 lost for follow-up. So they had 49 patients. And you have to, so if you look at them, at 6 months, you have 49 patients. That is because this is an ongoing process, and the other, how many of them?
33 had reached that 1 year.
33, only, let us say you start your study from April 1st. So from April 1st, if you start, and then on October 1st, you would have had a 6-month analysis. So, but then there are patients whom you have operated in August, September. They would not have been, they would not have reached the time for analysis at 6 months. So at 1 year, there are about 33 patients who have reached 1 year, and the 16 patients who have not yet reached 1 year. You understand? It is an ongoing study. So you can't, they would not have recruited all the 49 patients on April 1st and studied them for 1 year. It is an ongoing study. So as and when patients came and as and when the inclusion criteria were, satisfied, they would have operated on them, or they would have done this procedure on them. So you would have patients who would have completed 6 months, 8 months, 9 months, but minimum of 6 months, follow-up you need. So maximum of 1 year as of now. Did you follow?
yes, sir.
Okay. So
Sir, but it might also be like 20 at the end of 6 months follow-up, there were like 49 patients, and then at this thing, 33 means some might have recurred also. No, that also can be. That's why that data is confusing. I think that is why she is confused. Because this is the flow chart of that entire study. They have not said like this thing. So at the end of 6 months follow-up for each patient, they had 49, out of which 5 had withdrawn, like 4 had withdrawn, like 3 withdrew consent and lost to follow-up. So then again, after 6 months of follow-up, at the end of 12 months of follow-up in the entire study, they had only 33.
No. I think basically they should have made it more clear. See, you
Correct.
start recruitment from April 1st. So at the end of 1 year, there are 49 patients who have completed minimum of 6 months follow-up. And
Correct.
33
So,
patients have completed a minimum of 1 year follow-up.
1 year follow-up, they're finished, and the rest of the 16, they're still ongoing. They're like, it's not yet finished 1 year.
They should have made it more clear. Yeah.
Yes.
Unrelated, sir, then in that scenario.
Huh?
In that scenario, they should be unrelated, both two different set of
No,
patients.
No, total is 49 only, Nikita, if you calculate. So at the end of 6 months, everyone had 6 months follow-up, except those 4 patients who withdrew. So after that, they have continued to be on follow-up, the rest 49 patients. So in that, at the end of 12 months, out of 33 patients, they who have finished 1 year follow-up, in them 20 has healed and 13 has failed. And the rest of them have not yet completed 1 year. It might be that they might be having 34 healed. Why you are getting confused, I understand. Because in n is equal to 49 at 6 months, they have said 34 have healed. So if 34 have healed, then it should be like they should have showed here that 34 has healed. Probably that at the end of 7th month or 8th month, they might have had a recurrence. We don't know. So that's
But
why that healed number is lesser here.
sir,
So I
but they
understand
also
why you are getting confused.
they also
Okay,
statements.
one more doubt.
Yeah.
In the 49 patients, 15 have failed. Why did they follow that patients?
No, they have allowed it to heal. The failed means that it has not healed. So probably
it is the
patients and
failed
all that
means
it
it
might.
is. They should say it is ongoing healing. It's not.
No, that is why the table is confusing. So 15 failed at the end of 6 months means probably what they are thinking or what they wanted to say is 15 have the wound, 15 of those wounds out of the
Because 6 months
49.
is a sufficient good time for any wound to heal.
See, that is why
Crohn's disease and all that they have included. No, so probably that is why. So sometimes they may be on treatment and might have taken a longer time to heal.
Nikita, they
Yes,
are
sir.
not different group of patients, ma. See, it is like this.
See, in the 33 patients, 13 failed.
Srikanth, one nimsha. They have started the study from April 1st. Just imagine. Okay.
Yes.
April, they had 5 patients. May, they had 6 patients. You just carry on like this.
Yes,
Okay.
sir.
At
Yes,
the
sir.
end of 1 year, you had 49 patients. Out of them, if you analyze them, only all the 49 obviously would have a minimum 6 months follow, right?
Yes, sir. Yes, sir.
Then, for example, those recruited, let us say in August, they will only have 6 months follow. But those recruited in April would have 1 year follow. You follow? Let us, if we are analyzing on April 1st, started the study on April 1st, 2022, and
Yes, sir.
start analyzing the data on April 1st, 2023. Okay.
Yes, sir.
So there are 49 patients in totally. But out of them, maybe there are only 33 patients who have completed a 1 year follow-up. But then the others are all, they have completed a minimum of 6 month follow-up.
Sir, that everyone understood. Why they are getting confused is because at the end of 6 months, they said that 34 have healed and 15 have failed. So when they have continued to follow up those patients, 16 of them have still not completed 1 year follow-up. So they have not given the data. What is we assume that it is healing. So that means 15 who had failed, that has become 13 now. But healed only like out of 34 who had healed, now they're saying 20 healed. That means few probably would have had recurrence. That is what this table means. If the same set of patients are continuing to be on follow-up. So that is where the confusion is coming.
Right.
So if you see there, 34 have healed at the end of 6 months. If it is the same set of 49 patients, then those healed should not, if there was no recurrence, then here also it should have been 34.
And the recurrence should have been showed again in the failed, sir, again.
Correct. So that is what the data is confusing here.
Okay. What else, Nikita, what are the other factors in the...
Praveen, is there any explanation for this in detail in this one?
No, sir, they did not give, sir.
Nothing.
Might be after completion of the 16 patients of follow-up also, they might start to include in this research, sir.
No, Praveen, you are not getting. Sir, Ravishankar sir said, and that is correct, that they are studying only that 49 set of patients. But what is confusing is at the end of 6 months, they have said that 34 patients out of those 49 have healed. So if it is healed means then at the end of 12 months also, the healed should be 34 only.
Yes, sir.
But they are not yet finished 1 year, alwa, sir.
They have not yet finished, correct.
They want to show.
They have not yet finished 34. Then they should ongoing. They have said n is equal to 16. There they should have showed at least how many of them have healed.
Yes, sir.
That is where there is a confusion. You understood? So 20 healed means less 14 should have been shown in this ongoing, that there is healed. And here that numbers are not matching. 34 healed means 20 healed in the 12 months follow-up, they have finished. The rest are still not finished. That's why they have not showed the data. Means they have should have showed, or in that 1 year follow-up, who have not completed that 1 year follow-up, 14 wounds have already healed. If that was given in the bracket here, then there would have been no confusion there.
Yes,
Correct.
sir.
Okay, Praveen, what are the critics?
For they had done a good follow-up, sir, of all the cases and analysis. Against I could not find, sir.
This what we have just said, no? Confusion.
Yes, sir. They did
Sir.
not clarify the data. sir.
Clarified. Srikanth?
I didn't follow anything. I'm fully confused.
Allah, I think I basically see my understanding is they don't have the data for all the patients at the end of 1 year. So they have done 6-month analysis, 1 year analysis. But the problem is that if the 15 have not healed, now what has happened to them at the end of 1 year? I know that is not clear. So that is the problem.
Sir, can I say something, sir?
Yeah,
Because
yeah.
they have written in the very first line that only 49 patients had reached the 6 months follow-up and 33 had reached 1 year follow-up, which
Correct.
means I feel that the remaining people, that is around 16 patients, have lost a follow-up from 6 month time to 1 year. That is what I think they meant to say, sir.
So they
Like,
have not,
No, they have not mentioned lost for follow-up. If you go back, at the end of 3 months, they have said lost for follow-up, that they have excluded. If they had lost for follow-up, they would have excluded them out of the study. Here, that 16 means they have not completed 12 months, that we agree. But because they have told out of those 16 patients, 14 patients, they had showed that wound had healed. So they should have showed the same 14 set of patients that it is still ongoing. But we are keeping them under observation for 1 year. But the 14 wounds had already healed at the end of 6 months. At least that part they should have clarified. That they have not done. That is where the confusion is arising, because it will skew the data one way or the other. Either it will be a very high recurrence or it will be a very good this thing. So that part they are not very clear here.
okay, sir.
Yeah, go for discussion, man.
Sir, in this study, they have performed the first in-human assessment of RD2 version 2 for management of simple and complex transpenetric anal fistula. And the interim analysis showed that the healing at 6 and 12 months was 69% and 60%. In addition, they have seen that in all patients who were healed at 6 months remained healed at 1 year follow-up mark. In recent years, there have been several attempts to create an injectable material capable of effectively and permanently closing an anal fistula tract. And this included the fibrin glue, plugs, and mesenchymal and adipose derived stem cells. However, the success rates with injectables have been modest, and there is some improvement with fistula drainage, but with a healing rate of only 41.7% at 12 months.
Wait, stop here. What is the fallacy in this statement? Anybody? There is a big fallacy. The fibrin glue, plugs, mesenchymal, and adipose derived stem cells. They have included all of that. Anybody? Nikita, Sanya, Aina, anybody for that matter? Nitya?
I didn't.
Huh?
I didn't answer.
What? There is a major fault in that statement. These included fibrin glue, plugs, mesenchymal, adipose tissue, and all that.
Improvement in drainage.
Huh?
Improvement in drainage. Fistula drainage.
No, not that.
Does that mean that we don't, which one is the most effective amongst, like,
No. Tanya, can you think of anything, any major flaw in that statement?
No, sir, I don't know.
See, what is the latest craze? Platelet-rich plasma.
Yes, sir.
Heard of platelet-rich plasma?
PRP, yes, sir.
PRP.
Yes.
So PRP is actually the major player in this, and there are 2 huge meta-analysis and 1 systematic review with the meta-analysis of PRP from Journal of Cosmetology and Dermatology, so of 289 patients with the 65% success rate and recurrence of 12%. And another systematic review with meta-analysis, International Journal of Colorectal Diseases in 2023, 14 studies of 514 patients, cure rates of 72% with a combined cure rate, if it is included with other surgical procedures, of 83% and a recurrence rate of 14%. So, anything that is to be compared, you have to compare it with the platelet-rich plasma, because I think all others, these fibrin glue, plugs and mesenchymal, they have only 40 to 50% success rate. So you don't compare it with them and say, I am better. You have to compare it with something which is, for example, PRP in meta-analysis shows a 83%, a 2-year success rate, which is exceptionally good. So I think they should have compared it with that. So they obviously, compared it with some other studies which are not so good and said ours is better. So that is the fallacy. When you are comparing, your study with something, you should compare it with the current industry best. No, you can't compare it with somebody and say, Ferrari cannot say I'm better than Fiat. So Ferrari should say I'm better than, Bugatti or whatever. Okay, carry on.
A different strategy was anal fistula plug, which was a merger of lyophilized porcine intestinal submucosa, which serves as bioabsorbable xenograft and as a scaffolding material, which creates a physical occlusive device for fistular closure. Although it showed initial results were promising, but long-term analysis showed there was healing rate of only 40 to 50%, especially in complex cases. Stem cell therapy has recently gained traction in perianal Crohn's disease, but the long-term results which were published in Admired City trial show that the remission rates was of 56% compared with 40% in the control group. However, the indications for stem cell therapy are fairly limited, and there is little evidence on healing rates. Data suggests that RD2 version 2 may be effective for both cryptoglandular and Crohn's disease-associated transpancreatic fistula in INO, regardless of whether a previous attempt at fistula closure had been attempted or not. And this is a potentially less risky compared with other treatments because the patient's whole blood is the principal therapeutic agent. And this is a novel whole blood clot product that offers a functional extracellular matrix to protect and facilitate tissue healing. And these coagulation agents are mixed with patient's blood to accelerate clot formation. Resulting mixture is applied into wound cavities, which allows the coagulation process to occur inside the cavity and provide a fibrin scaffold and facilitates the tissue healing. Because the final coagulation steps occurs inside the cavity, this clot and its beneficial factors come into contact with the internal surface of the treated cavity. And it was proposed that this clot serves as provisional extracellular matrix and provide wound reepithelialization. And as this coagulation process occurs, the blood clot attaches to the exposed surface of cavities and contracts and causes the surface to draw closer together as it forms a scaffold. Previous studies have demonstrated that safety and efficacy of this technology in treating challenging non-healing cutaneous wounds and complex surgical wounds. And using autologous blood clots, which provide a transient scaffold and recruit surrounding cells to activate wound healing, it presents a promising strategy to treat open and chronic wounds. And they concluded that this RD2 version 2 treatment was found to be safe and effective in achieving healing in transpancreatic anal fistula of both cryptoglandular and Crohn's disease related origin within 6 months of treatment. Once healed, the closure seems very durable with minimal risk of recurrence. And prior therapeutic intervention does not interfere with application of RD2 version 2 and potential successful fistula closure. Further comparative studies are needed to confirm the potential benefits of RD2 version 2.
Coming to the methodology, Praveen, they have not described, for example, complex fistulas and multiple internal openings. They have not said whether they would close all the multiple internal openings or they just close one of them. And how do they ensure that the clot goes into the branches and other things? And they have not mentioned all these things. So, because they say that they are treating very complex fistulas with many side branches, multiple openings and all that, complex high fistulas and things like that. They have not described how will they ensure that this blood clot enters all the side branches and everything.
And
Yes, sir.
also for Crohn's disease, have they standardized the treatment? What treatment all those patients are receiving or what they have received?
They're all on biological. So
All are on biological, same for a fixed number of time.
the problem is
Yes.
if they're on biological,
Then that will itself make it the fistulas to heal.
biologicals themselves are known to heal the fistula. So you can't take the Crohn's disease results at all because you don't know whether it was the blood clot or the biological.
Biological.
Because
Yes.
in those situations, Crohn's disease, you don't have to do anything for fistula until and unless there is an abscess there. So need not have to put this thing, and they have not, as sir said, they have not even mentioned how many openings were there, how many whether you have to instill into the all the external openings. So that is also a downside. You can't conclude it for Crohn's disease.
So, but
Yes,
I
sir.
think Nikita, would you answer this question? Is it clinically relevant?
It is clinically relevant, sir.
Would you change your practice?
No, sir.
Why not?
Based on just a pilot study, I would not like to change the practice, sir. And the conventional complete fistulotomy or fistulectomy is
See,
more
even the fistulectomy, what is the recurrence rates, ma?
7 to 50%, sir. But the
Hmm.
problem is these are like innovative procedures. They're trying to minimalize the invasiveness.
No, the thing is, recurrence rates with fistula, I think, are vastly underreported because majority of the time, especially of course in Indian setting, people go elsewhere. So we don't know what is the true recurrence of our the true results of our procedure. On the other hand, in the other countries where follow-up and things are a bit more standardized, still recurrence rates are quite high but underreported. So this is, very safe because you're using the patient's own blood, and I think that no harm, by trying it out. I think it is something worth considering. As you said, it may be that we can do a study between platelet-rich plasma and patients' clotted blood and see which is better. And then, because you have a comparative study, then you can, see whether one is better than the other, and then see how it goes.
Yes, sir. That would make a difference. Yes.
Tanya, would you change your practice?
No, sir. Not. I don't think so.
But it is certainly worth considering because
Considering, yes, sir, maybe we can consider in patients whom we have tried fistulectomy or fistulotomy and it has recurred. I mean, patients
not
who
just that.
don't want.
No, you can even include people with fresh fistula also, because it is, there is no major invasion. All you are doing is cleaning up the fistula, inserting the blood, and hope for the best. If it recurs at a later date, then you can do another procedure. So nothing
Yes.
wrong. I think it is a fairly, as an initial procedure, it's pretty good. Niranjan?
Yes, sir. It is not damaging, but problem is that how do you take care of the offending anal gland complex by just by injecting a blood clot? Because that is where the recurrences happen. So, and the data is only 6 months old, although it is a relatively harmless procedure, no harm in trying when there are multiple failures. But still, the data needs to be convincing.
Yeah. So, Srikanth, what do you think? Would you change your practice as of now?
No, not change, because my recurrence rate is lower than what the recurrence they have shown.
So, I think it is a thought-provoking process. I think
Has anyone else done the study?
No, this is the first study. So that is why
That is why
we
cannot
have
be
to
taken into practice.
multiple studies are required which replicate the results, and then comparatively, maybe comparing it with the platelet-rich plasma, then maybe we can consider. Okay, so Niranjan, you want to do this as a journal club? Because my only thing is there are.
Sir, the data I think is little confusing.
Yeah,
Rather than doing this, we will do the last times this thing, Nikita's, that she had spoken about the primary closure with vac abdominal this thing, wound closure.
Yeah, because
That-
there is statistics is not there, so
Correct.
it is something you want to.
And also data is like confusing. That is not, they are not very clear.
Correct. I think.
So we will do the previous, that Nikita study.
Okay.
Okay.
Right. If there are, I think Praveen, you have done a good job. Niranjan, your
Thank you,
comment on presentation.
Sir, it was good, sir. Whatever this thing is there, it yes, presented well.
Because there is no, I also searched, there is no collateral reading for this. Is that
Yeah,
what-
yeah.
Yes, sir. Actually, searched it, sir. But as you said, PRP is a recent one. I thought to add it, sir. Here,
Hmm.
whatever you said, the meta-analysis.
Yeah, yeah. Good. Hmm. Yeah, you can share this. Share it.
Yes, sir. A meta-analysis was conducted in 2022 of 6 case control studies and 3 randomized control trials of 289 patients. And it showed that the cure rate was around 65% and recurrence was around 12%. And they have suggested it as platelet plasma safe and effective in treating anal fistulas.
Okay. Other one?
So it's also the same, sir. Platelet
Ah,
yes,
all
that
type
will-
of fistulas, is it?
Sir,
All type of fistulas it is. Complex fistulas, simple
Yes, sir.
fistula, everything they have taken.
Yes, sir. They included all the fistulas, sir.
I think next year we can probably think about doing platelet rich plasma. This for fistula. Maybe a good thing. Good thing.
Okay, okay, sir.
So, Srikanth, your final comment?
Good presentation.
Thank you, sir.
But you should have that follow up this thing recurrence rate you should have discussed before presenting here, and got a good clarity and then presented. A whole lot of
Okay, sir.
confusions.
Okay, sir.
Okay. Sania, final comments?
Good presentation, sir.
I think, yeah, Praveen, you did a good job of presenting well, but I think there is problem with their data presentation, so which is something we can't do anything about. So I think that is the reason why there was some of that confusion, which I think was genuine. Otherwise, it was a good presentation. So well done. All
Thank
the
you,
best.
sir. Thank
Good
you,
luck.
sir.